Good evening, Dr. Horsley.
Oh, good evening, ladies.
Good evening.
Thank you once again
Good evening.
for joining us, and thank you for sponsoring through H2K Canada. And full disclosure, I'm not associated with the company, but I sure recognize their wonderful products. And when I visit pharmacies to tell them about New Remedy, I see a lot of H2K products on their shelves, the Motrin, et cetera. And my two favorites are the Bora Total and Diabasoft. Bora Total is a cream with neem in it, and Diabasoft is for soft feet, and you do not have to be diabetic to take advantage of this product. We wanted to once again welcome all our guests. We have patients, we have physicians, colleagues, pharmacists, family, friends. We have folks visiting from Canada and other parts of the world, US. We always appreciate you coming to be with us and participating. Now, I was wondering if Dr. Mitchell is in our group this evening. Dr. Mitchell?
I'm here.
Right.
Good evening.
Oh, good evening, Dr. Mitchell. Hey there. Hey there. Good to have you join us.
Thank
We have
you.
you. You always, you've been with us before and have shared information that has been so valuable that we had to have you come back, do it one more time, because your insights on the diabetic foot are very nice. So without further ado, Dr. Mitchell, if you could hit that share screen button, we'd like to have you see what your information's about this evening.
Okay, good evening, everyone. Thank you so much, Dr. Horsley and the team, for having me. It's always a pleasure to be on the program and to be able to share with everyone. I'll open my camera. Okay. All right. So I'm just going to get started because I know the time is running. So this evening, I want to talk about the diabetic foot. And I want to say thank you to Dr. Horsley and everyone else because this is something that I love to talk about. And so I'm very happy to do that. Oh, wait, I'm not advancing. I don't know why my slide is not going. Okay. I'm having technical difficulties. I'm going to stop sharing and share again. See if that helps.
Okay. Take your time. Looks like you're right out there at Goodman's Bay. With that background.
Okay, that did it.
Yep. Looking
Okay.
good.
So this evening we're going to talk for about 15 minutes about the diabetic foot. And I'm hoping that it'll bring a little bit more clarity to the topic and help us to, I guess, be more, sorry, knowledgeable about it. So our objectives for this evening are just to recognize the impact that diabetes have on the feet that leads to the lower extremity complications, and list at least two common diabetic complications that increase the risk for amputations, and then look at what we can do about it. So at least two things that you at the end of this would be able to say what can prevent amputations. So, let's start at the beginning then. So when you hear the words diabetic foot or diabetic feet, a lot of times persons have different understanding of what that means. And so you may have had that diagnosis, or a family member may have had that diagnosis, or you may even be a healthcare provider who would have seen that diagnosis on a chart or in a patient's record or something like that. Or you may have been attending our meetings and heard the word diabetic foot, words diabetic foot, and wasn't too sure about what it is. But the International Working Group of on the diabetic foot in 2019 defined diabetic foot as infections, ulceration, and destruction of tissue of the foot that are associated with neuropathy, which is the loss of sensation, and peripheral arterial disease in the lower extremity in persons with diabetes. So that is what we're talking about when we talk about diabetic foot. And so it's a very common diagnosis, especially if you work in Princess Margaret or some other hospital. You will see that it's a very common diagnosis. So when you think of diabetic foot, you may have different pictures in your mind, but for me and Dr. Horsley and a lot of us who work in this area, these are what we see every day. So I call them the faces of diabetic foot. So you see
Okay.
different things every day as a result of how persons present with diabetic foot complications. So those are some others as well. But the most important thing about the diabetic foot is to know why it occurs. And the reason it occurs is, if you can read with me, the red line says persistent,
Persistent,
uncontrolled
uncontrolled
high blood
high
sugar.
blood sugar.
Exactly. So if that research and experience has shown that persons who have diabetes and their diabetes is under control, meaning their A1C is less than 7, their rate of developing complications is so much lower or delayed significantly because they kept their blood sugar under control. So this is a central theme of what we're going to be talking about. Persistent uncontrolled high blood sugar leads to permanent changes in the lower extremity, and you can see some of these diabetic foot complications here: amputation, infections, ulcers. These can all occur because that blood sugar was not under control. So let's take a moment and look at how diabetes actually affect the foot. Why do we call it the diabetic foot? So the first thing that's affected is the blood vessels and the blood flow to the feet. Okay? So persistent high blood sugar damages the blood vessels and can actually lead to peripheral arterial disease, which is poor blood flow to the feet. And of course, we know that this will result in either no healing or very slow healing or delayed healing. Also, it can lead to gangrene, as in this picture up here in the top. And of course, amputations can result as well. The nerves, of course, is the next area that is affected. And in fact, the nerves are actually the most predictive of the lower extremity complications. Once the nerves are damaged, then that is when the risk of complications increase exponentially, meaning multiply upon itself, not one by one by one or one times one. So that is what causes a lot of the complications. So persistent high blood sugar actually damages the nerves, leading to diabetic peripheral neuropathy or diabetic nerve pain, a lot of laypersons would say. And we can have sensory loss, where you can lose sensation of feeling in the feet, and then numbness, tingling, burning, or even a slipping slipper sign, where persons walk out of their shoes and don't feel it. Or you can have motor neuropathy, where the muscle wasting, for example, in this picture here with the patient here with their toes all curled over, that is a motor neuropathy. And you can see that they have hammer toes on all the toes. And so then, of course, that leads to imbalance in the toes or in the feet and leads to deformities and increased pressure. Where there's pressure, there can be callus, there can be ulcer, there can be amputation. So it's like a stepwise approach as a result of that. So the nerves are very, very, very important in everyone, but especially in the diabetic. So this is something that really leads to these complications when the nerves are damaged. The structure. The structure of the foot is the third area where the diabetes affect the foot or the functioning of the foot. So again, I am sure you're hearing a trend here. Persistent high blood sugar. Every sentence begins with that. So damages the tendons, the ligaments, and the bones that can lead to deformities. In addition to the nerves, can lead to deformities and changes in the shape of the foot. So if you look at these pictures here, okay, so this x-ray picture to the bottom here is actually a picture of a Charcot foot, where you see the bone is protruding on the bottom. That results in the ulcer of hair, and that will take a very long time to heal, if it ever heals. Will need surgery actually to get that to heal. And so again here, we have another ulcer here. On this foot here, this person had to have an amputation, so they lost the toe. And so that also leads to imbalance. Increased pressure can lead to ulcers and can lead to amputations. So definitely we see that once the structure of the foot changes, definitely we need to be more alert and pay more attention. So number 4, for the skin, persistent high blood sugar again damages the temperature and moisture control mechanisms in the skin. So we can see from this picture, this lovely picture here, okay, that this person here, they have a very dry, cracked skin that actually ulcerated. So as a result of having no moisture or low moisture in the foot, you can see cracks here in the heel as well. That can all lead to calluses, ulcers, skin infections, and eventually can be at risk for amputation as well. So here are some pictures or some ulcers that we may see in our practices on a regular basis. Okay, so again, the integrity of the skin is compromised because of the changes that is occurring because of the diabetes. Number 5, and the final way that diabetes affects the feet, or the, well, it's the whole body, but persistent high blood sugar actually damages the functioning of the immune system and its ability. It compromises its ability to fight infection. So the neutrophils, we all know, are like the defense force of our body. It's those are the fighting cells that go out and kill bacteria and everything else that's causing infection. So the neutrophils actually become ineffective when the A1C is above 12. In fact, just sugar consumption or high blood sugar, circulating high blood sugar levels actually decrease the functioning of the neutrophils. It's like they go to sleep. They don't function, they don't work. Okay, and so of course we can see that this would increase the risk of infection, and then coupled with lack of blood flow or low blood flow, treating an infection would definitely be a challenge. So this is our review. So the take-home message here is that the diabetes affects the feet in specific ways, and as a result of those effects, it actually makes the feet of diabetics at high risk for ulcers and amputations. And so as we really need to look at protecting the feet and preventing these complications. There are a lot of facts about diabetic foot and what they are and what is going on. I'm not going to read those. I'm going to make the PowerPoint available to anybody who wants it so that they can have it. But some of the highlights I would like to say is that 85% of all diabetics who get an amputation first had an ulcer. So if you can prevent that ulcer, maintain the integrity of the skin and prevent that ulcer, you almost guaranteed in 85% of those cases to prevent an amputation. Another slide I like to mention is that the mortality or the death rate from persons who have diabetic foot ulcers or foot amputations far exceeds those persons who have prostate and breast cancer. So if you can look at this here, these blue ribbons here, we recognize these very well, the pink and the blue, breast cancer and prostate cancer. But on the other end of the spectrum, the higher end, this gentleman here lost a leg, and then this green um, 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 ribbon right here represents someone who has an ulcer. So we can see that the mortality rate or the death rate of persons who have ulcers and amputations is significantly higher than those persons who have breast cancer or prostate cancer. Now, this is something that I think we all need to recognize. Okay? This is every 20 seconds. And as I speak, you will see the timer goes down. Every 20 seconds, a leg is amputated due to diabetes. And this is worldwide. So in 20 seconds, you will see that someone would have lost a leg. So I just wanted you to feel what 20 seconds feel like so that you can see the frequency at which persons lose a limb. In the Bahamas, it's estimated that 1,000 persons get an amputation as a result of diabetes every year, and worldwide, that's 1 million persons get an amputation. So we can see that this is a significant problem. However, we don't see the the concern or the passion for it like we see some of the other conditions. Now, that is what I wanted to cover about the diabetic foot, but I could not close without telling you some things that you can do, because it may sound a little bleak, but there are 7 steps that you can do. And Dr. Horsley, maybe I'll have to come back to talk about this one in details, but I just want to cover
All
this.
right. All
We
right.
know from our discussion tonight that the high blood sugar contributes to all these complications. So you can just figure it out. The number one thing that persons with diabetes can do is to control their blood sugar. Control that blood sugar, and it will prevent or delay these complications. And you can control that blood sugar by lifestyle change. Definitely medications, tablets, or insulin will contribute to that. Do not smoke, because it further exacerbates the vascular problems that you have in diabetes. Prevent injuries. Footwear, wear the proper footwear. Foot care. What do you do to take care of your feet every day? Or what do persons with diabetes do to take care of their feet? Foot self-exam. This is something that I love to do, teaching my patients about how to care for their feet and how to look at their feet every single day. You will only know if there's a problem if you look at your feet every day. And then number 7, get help as soon as possible. See your podiatrist at least once per year. Once you see the podiatrist for preventive care, not in the time when you have the ulcer or anything like that, preventive care. Research has shown that almost 40% that decrease your risk of amputation and hospitalization by at least 40%. So it is important to see a podiatrist regularly so that you can get preventive care. My last slide now. This one here, I hope you get it, but I love this slide because a callus, we all know a callus, or we should know that a callus is hard skin. So this here, if you look at this first picture here, this is callus, hard skin that's on the foot. Oftentimes, this is a clear callus, but sometimes calluses would be different colors, blue, black, red. Underneath the callus, you'll see colors. When that happens, there is an ulcer under that callus. And so you will see that is what is showing through. Callus increases pressure, which can lead to an ulcer. Leading an ulcer can get infected, or a poor blood flow can actually lead to an amputation. So I think of a callus on the foot like I think of a breast lump. A lot of us in here are women, and you would not find a lump in your breast and just sit home and do nothing about it. Most of us would be very frightened and we would go to the doctor that very day. So I want to impress upon you, or if you know somebody who has diabetes, to impress upon them that a callus is just like a breast lump. So if you have calluses on your feet, especially if they're colored, you need to do something right away. Get to the podiatrist, go to Dr. Horsley, go to myself, somebody else. You need to get somewhere fast, because that is not a good thing, and it can actually lead to amputations. So early detection saves lives, just like it does in breast cancer or other diseases. The same thing is true for the foot. So I would just like to say, let us all continue to educate ourselves, educate our patients, our family members, so that they can all keep their feet for life. And the only way you can do that is if you're knowledgeable and you're willing and you're able to do what it takes to take care of your feet. Thank you so much. And that's my presentation.
Oh, nice, nice, nice. Dr. Mitchell. I think we should just stop the Zoom after that excellent presentation because one thing for sure, I think you have the password to my phone because those look like a lot of the pictures, those photos look very familiar. I'm like, oh my goodness. And I know they're seeing, it's a different person. You're seeing that Dr. Johnson is seeing, Dr. Kemp is seeing, and everyone else who's a podiatrist and some of our primary care
Care
doctors.
doctors as well.
I want to thank you, Dr. Mitchell, because I'm losing a little bit of weight with this Zoom because every time I see pictures of those ulcers, I lose my appetite. So and they're like burning calories for me. So, but on the real side, what takes so long for people to come in? What is
Well,
maybe you've already spoken on it, but what do you say is one thing?
one of the reasons why diabetics, and in fact research shows that they tend to report to the healthcare between 2 weeks to 21 days later
Yeah.
than somebody else who have sensation intact. So one of the reasons is the neuropathy. Oftentimes they will not have pain, or they will not have anything to alert them. Paul Brand was a famous neurologist, I believe, and he said the gift of pain. That was one of
Oh,
his statements, was the
right.
gift of pain, because we have pain to alert us to something is going wrong or something is amiss. And so, because we have pain, oftentimes we will do something, we will go to the doctor, we will check out the situation. But because a lot of diabetics are neuropathic, they don't feel pain, or they don't feel any abnormality on the feet, then that delays them coming in to see the doctor. Oftentimes, they will actually come when they see blood, or they actually smell an odor from a wound or something like that. So, oftentimes, they may not actually feel pain. So, that's why it's delayed when they're coming in.
Oh, well, thank you very much. Hopefully you'll hang around to the
Yes.
end of the hour in case anyone else has any questions for you. I see some lovely comments in the chat room and congratulating you. So go ahead and unshare your screen, and we're going to see if Crystal is on the line tonight. Crystal Woodside, Tally Woodside.
Hi, good
Okay.
night, Doc.
Hey, hey. All right. Well, like I said, we could have ended it right after Dr. Mitchell, but
I
I
know,
know we.
right? She basically explained every single thing.
Yes.
Great
Right.
presentation.
Right. And well, one thing for sure, when Dr. Mitchell had mentioned that sometimes other people will alert the diabetic that they have a foot problem. And
Mhm.
I think that you are one of those people. And you have first
Thank you.
contact with a lot of patients, a lot of people. And why do you have first contact? What do you do for a living?
Well, I am a certified nail technician in the beauty industry here in the Bahamas, and I specialize in that of foot care and foot hygiene.
Okay. Well, do you have any presentation for us this evening?
I do apologize. No, I do not have any presentation as I am experiencing some technical difficulties at the moment, but I can send the presentation over once everything is completed.
Oh, we can just have you come back because this would be a pleasure to talk with you this evening to tell us about
Always. But I
one of
do
the
want to
things.
share.
Yeah.
I do
What's
want to share. I can say most definitely, as a beauty professional within the industry, you would have a lot of individuals that would come into various salons or beauty settings, and they would have various problems with their feet. They would come to have a pedicure service done. However, as we all know, for a diabetic, they even have to be extra cautious when having those type of services rendered within that type of setting. Normally, at times for a diabetic, because they would be experiencing various deformities with their feet or concerns about their foot, they would have calluses, they would have ingrowns, they would have pressure points that they need to have alleviated or reduced down to ensure that they continue on with their day-to-day life, because it can be very painful over the course of time once not taken care of on a monthly basis, especially.
Right.
Yes. So with diabetics, we all know, especially from Dr. Mitchell's presentation just now, they are at-risk individuals. So any individuals with foot ulcers, even possibly they can have amputation as well. They have to take extra special care of their feet, and it is very crucial. And the diabetic forecast, which I'm actually taking this from off of the internet, it says that you can go out there to have a pedicure service done. But like I said, you have to be extra cautious with having those services rendered within a salon environment. Mainly, you want to make sure that all the implements are disinfected and or sterilized before having your services rendered. You want to check with the nail technician. You want to check with your advanced nail technician to make sure all of the aseptic process and the cleaning process and the disinfecting process is done properly. So within the industry, we are, for individuals within the nail technician area or the nail industry, you have persons who would have advanced their studies and advanced their training to be able to still see and service these high-risk individuals within their salon settings. So they would have gone and taken advanced training on site. They would have gone to various facilities, medical facilities, in order to receive their training. So you have medical nail technicians, you have advanced nail technicians, you have foot health practitioners, you even have foot care nurses. So all of these individuals can maintain your foot care needs as it relates to a diabetic or anyone that is experiencing any form of callus buildup, thickness of the nails as it relates to dystrophic or lifting of the toenail. If you see your toenail is looking discolored, if you see there's any abnormality other than the normal, and normal is that of a nice, shiny, healthy, light pink hue under the nail, which is the nail bed, you want to have that nice, clear, nice pink hue to it. So anything outside of that is considered to be abnormal.
I
You still able to hear me?
understand that you do medi-pedis. What is the difference between a regular pedicure and a medi-pedi pedicure?
So the difference between, and great question, the difference between a medical pedicure and a regular pedicure is that a medical pedicure is a medical grade pedicure, meaning that all of the implements, all of the equipments, all of the tools that are used on each and every patient or client, they are sterilized with an autoclave. So with a medical nail technician and advanced nail technician, anyone within the industry that would have taken advanced training in nail technology would then take the next step, which is sterilization of your implements to ensure that you have a nice, clean, safe environment. You should not be catching any nail fungus from any provider at all, or you should not be experiencing any form of trauma at all to the nail in the service.
Right. So how about soaking the feet? Do you use the same tub in a medi-pedi?
With a proper
community?
medical grade pedicure, it is advised, especially for individuals who are diabetics, not to soak the feet at all. Not to soak the feet. So with a medical pedicure is more of a dry process. And a lot of individuals, because some persons definitely would have gone to have a pedicure done within a traditional salon setting. And we know you soak the feet until that foot turns prune and it gets all wrinkled up. But actually what water does is draw out all of the moisture from out of the feet. And we don't want to do that. So we want to make sure that you retain your moisture and add more moisture if it is needed, considering the skin and the texture of that particular patient or client's foot at the time. So consultation is then done even before a service is rendered to an individual. With a medical pedicure, everything is dry, all of the tools are sterilized. Even when it comes to towels, towels are being used one time, so it's not being reused over and over and over after each and every client. With individuals, and some of my colleagues definitely may be on now, and we can attest once you follow us on our various Instagram pages and our social medias, we go the step beyond that of a regular and a traditional nail salon. So we talk to you, we have that consultation with you to make sure that we're providing the care that you need for your feet and also your hands, because it just doesn't stop there.
Excellent. Now I see a couple questions. Well, one question could have been for Dr. Mitchell, but I know it's for you also. You do ingrown nails, because I know you've got one out for me. But
Yes.
it was, and but
So-
Dr. Mitchell does a permanent one also.
Within what I love to educate my patients and clients about is that before your nails totally become curved or involuted, we say, before it gets to that level, we do have a procedure within the industry that we use and that is seeing great, and I mean, it's such a great and marvelous effect that it's having, and it's changing lives. I just had a client that explained to me the testimony, and she gave the praise about this particular product line that is being used in the industry right now. And it's a
Pencil.
band.
Good gray pencil.
I don't know.
You're good. Keep
Pencil.
talking.
Okay, needs a gray pencil.
Okay. And the band is being placed over the toenail. So what it actually does is, because you would have had that curvature, but before the nail actually pinches into the nail bed, that can cause that inflammation in that area, infection that leads to that ingrown, which you would have to go and see your podiatrist for. And shout outs to all of you guys on Dr. Mitchell, Dr. Horsley, and Dr. Johnson, if they're on it, all of the medical professionals. Before it gets to that level, there's a band that we actually place over the nails so as to gradually, as the nail continues to grow out, it lifts the nail up to at least 5 millimeters to alleviate all of that pressure that that individual is experiencing on their side walls to their nail bed.
Well, Crystal, two quick questions before your time is up. One, I see, good. Two people have questions now. I see Courtney and Dr. Jefferson is on. He's a podiatrist in the Washington, D.C. area.
Hi,
And
Dr.
I know you followed him. You showed me you following him. Now he's following you back right here on the Zoom. And so
the awesome work that he is doing, it's marvelous. We share it all the time. I share it with all of my colleagues all over the world.
Oh, excellent. So do patients, diabetics, ever bring their own implements or their supplies to you? Oh, these are my nail clippers.
You do have individuals that do, but how I like I say, I try to educate our lovely patients and clients that actually come in to have their services rendered. I explain to them that the products or the equipment that is being used on you, they are sterilized. They're in a sealed individual pouches, and I indicate the indicators there on the pouches. This indicates that it's actually being sterilized in an autoclave. However, if individuals choose to still have their tools used during their service, we go through the same process again. So we still inform them, we still would have to do the same process for you. We are not sure where these tools may have been. You may have taken them out of a drawer. We're not sure what all is in that drawer. You may have some socks and some dirty shoes inside that drawer. We don't know where they're coming from. So we're taking the same aseptic procedure to make sure that everything is nice and clean and sanitary for you in a safe environment.
Okay, Tiffany, can you unmute Dr. Jefferson, Kevin Jefferson, or can he unmute himself to ask a question?
Yes, can you hear me?
Yes, sir.
Very good evening, everyone. Thank you, Dr. Horsley. Very fantastic presentation. Again, Dr. Horsley says I practice podiatry here in Washington, D.C. And what we're seeing here in the States is a increase in the number of podiatrists who are no longer offering nail care, even for diabetic patients, whether it be for insurance reasons, or they don't want to dedicate the time it takes in their offices because they want to do other things. So what some of them are doing is that they're bringing in certified medical nail technicians into their offices as an employee or as an adjunct service, or they're just making referrals out to those who work independently. Is this something that you're hearing about? Is this something that you're seeing outside of the United States, whether it be in the Caribbean or other parts of the world? And if you have if you could, how CMNTs can foster that relationship with podiatrists?
What do you think,
Thank you very
Crystal?
much. Go right ahead, Doc.
Hey, I'm old school, so I do ingrown nails, ingrown anything. So whatever's growing in your foot, if it's a IPK or a seed corn or whatever, I'm there for you. And I've seen you do that and Tiffany do that in the Medi-Pedi area. So, but you have first contact. And so do you do a lot of referrals or any referrals of your patients once you see them? Do you ever send them to a podiatrist?
Myself, yes, I
Yes.
have. And I have done that over the many years that I've been in the industry. I've been in the industry a little over 17 years, and getting more advanced into foot care and the feet and whole, because I became more fascinated about the feet after working in the hotel industry for a very long time in the beauty salon there. And I saw persons from various walks of life. And most important that I saw here, and I saw the niche here in the Bahamas, is that no one is really catering, at least in our industry at the time, to feet, and feet were becoming neglected. So all the time, anything that was out of my scope of practice, anything that looked like normal, I always referred to a podiatrist.
Excellent.
There was a podiatrist here in the country. She has now passed away. I always referred the majority of my clientele that came to me at that particular time, I referred them out to her.
Excellent.
And Dr. Johnson as well, yourself as well, Dr. Horsley.
Oh, yeah, you know.
I've done that so many times. And a lot of persons do not know unless they actually say it. But many times I would have called various offices, making appointment to make sure that my client is actually seen in their practice. So yes, I can advocate and say that individuals like myself within the industry, we are merging that gap that is now being seen with as it relates to diabetics and their feet, not having the maintenance. So there is a merger that's evolving. It's becoming a little bit more popular now than it used to before. And now you have individuals within the medical field that is seeing the need to have these individuals be seen from a foot care nurse, from a CPM, from a CMP, from an ANT, which is your advanced nail technicians. So there are many classifications of individuals within this field, but it's slowly but surely getting there. And some of my colleagues in the other Caribbean islands, they're now seeing the effects of the service being offered, because it is needed. It is needed.
All right, Crystal. Well, I want to thank you very much. We have a question from Courtney. I'm going to save that till after I give my presentation. And so I'd like for you to hang in there for another 20 minutes or so.
Thank you for having me.
We can entertain Courtney's question. Well, you're very welcome. Appreciate you for stopping by this evening. Next, we have Hillary Duncombe, who was on last month, and she spoke of diet considerations and diet changes. And today, Hillary wants to talk about diabetes and exercise. So Hillary, are you available this evening? Oh, good. All right. We can't hear you, so unmute.
All right, sorry about that. I was just
Yeah.
saying how those ladies were so good. I don't know if my presentation is even worth it at this point.
Same here. So we're
Especially
all-
with, go ahead.
No, we'll put Dr. Mitchell last next time. She's so excellent.
Especially with Crystal and the nail care. She made me miss the Bahamas so much. So thank you for that.
Right. So what you got?
All right, so today, as you mentioned, I'm trying to get there to my page here, but as you mentioned, I'll be
Okay.
talking about exercise and diabetes, and you guys let me know if you can see that.
Yes, we're clear. It's coming through. Looks
All
like she's
right.
at Goodman's Bay, her and her sisters.
Right.
And they're trying to stay afloat.
Yes,
Are they-
perfect, perfect. But once again, I'm Hillary Duncombe, and I just want to talk about this basic practical application as it relates to diabetes and how it can help to prevent certain things. So first, we'll start with an opening discussion and audience presentation. And I just need you guys to just think about an exercise, something simple that you enjoy or that you would like to enjoy. So I'll give you a moment to think about that.
Eating.
Hey, you have to put your hand to your mouth. So that's a good movement.
It
Anything
used to
else
be
other than eating?
the 9-inch curls, you know, I mean, the 9-ounce curl, the 11-ounce curls, drinking beer, but I cut back on my beer.
I hear you.
But
Well, that's movement. So that's a good thing. But
Yeah.
with that thought process, can you tell me, other than the eating, any other exercise that you can think of that you think can help a diabetic person or any other individual that can help them with their quality of life? Anyone can
Yeah, I
answer
see
that.
dancing. One of the answers is dancing.
One of the answers that,
Yeah, I see
okay.
dancing is listed for sure.
Absolutely.
Uh-huh.
Yes, yes. So that's what tonight's discussion is all about. It's talking about exercises that can improve quality of life for a diabetic or any individual. In particular, circulation health that can prevent or decrease amputation. And so at the end of the presentation, you will have basic knowledge of practical ways to improve your circulation through exercise. All right, from circulation rags to circulation riches. I'm privileged to be in a room filled with inquisitive minds, and many of you're familiar with what happens during poor circulation. And that poor circulation is basically a disruption in the circulatory system. In order to prevent this disruption, one must keep the blood vessels, the arteries, the veins, and most importantly, the heart healthy with a consistent and frequent dose of oxygen, nutrition, and blood. So there are many people who suffer from circulatory issues, or what I like to call a major disconnect within the body. One way to go from circulatory rags to circulatory riches is, you guessed it, exercise. Engaging in any type, and I just want to emphasize that any type of cardiovascular activity from about 30 minutes a day will keep blood flowing from the heart to the lungs for the body to get oxygen. So you can do it, just put your heart into it. So it's important to note that exercising is not about unrealistic or hard to obtain goals. This is not to say that your focus should not be about creating a body you're proud of, because a lot of people, as you can see, you have and all of those things. And then you have persons like maybe you or myself, just regular exercise. You just want to get up and do something. So what's most important is something engaging, persistent, and consistent. And that will promote a lifestyle change that is essential to good circulation and overall health. All right, how to keep blood flow from the heart to the lungs for the body to get oxygen. Most important. So these are some simple steps. So cycling. Anybody like to ride a bike? Simple,
Yep.
right? A simple lifestyle exercise. So cycling is a great way to improve circulation and overall cardiovascular health. And the reason why I put there lifestyle exercise, we're not talking about you have to leave your home, schedule time, go to the gym. We're talking about everyday things that you enjoy. So that's where the lifestyle comes in, something that you're going to have in your life that's permanent. Another thing is walking. I love walking. And walking is one of those exercises that you can walk at any pace. It doesn't matter, and you increase blood flow throughout your body. And look at that illustration there. You know, he's walking and reading. It actually happens. People do these things. You can be walking and texting. It's not the most safest, but if you're in a controlled environment, it's okay because you know what's around you. So walking every day can help you with your circulation. Another thing is swimming. Most don't know this, but if you swim in cold water, it flushes out the veins, arteries, and capillaries and increases blood flow to the extremities. And the extremity blood flow is very important, especially for diabetic patients, as we know. These are some of the issues that they deal with where they feel nothing. So if you're exercising and moving a bit, that's going to help with that blood flow. Lifestyle exercise, somebody said it, dancing.
That's right. And swimming, right?
Exactly. And this is another one of my favorites. And we never think about this. We never think that dancing is an exercise, but it actually is. Anything you do to exert yourself, build up your heart muscle a bit, that's exercise. So dancing may be the most fun and easy exercises out there. It improves circulation and reduces the risk for cardiovascular diseases. Nothing beats a failure but a try, everyone. One of my favorite quotes, nothing beats a failure but a try. So I challenge you to try a few of these lifestyle exercises, at least one of them per week or all of them, cycling, walking, swimming, dancing. The one advice I can give anyone who wants to get into exercise, who's been a bit behind the ball, is do something you enjoy. Don't follow the crowd, just do what you like. If you like to walk, if you like to cycle, swim, dance, whatever it is, just do it. So I'm challenging you, and this is a real challenge, guys. So when I come back next week, I'm gonna ask you guys, or next month, who took this challenge to heart? Who did it? And again, nothing beats a failure but a try. All right, so the takeaway today, simple, basic knowledge of practical ways to improve circulation through exercise. And we all need it. It's not just for the diabetic patient, it's for all of us. All right, so thank you again. This is Hilary Duncombe with Exercise and Diabetes. If you guys like what you heard today, you can go ahead and schedule me. I have my number there, also my email, simple, hilaryduncombe@gmail.com. And you just put in that subject line that it's from the RoundTable, and I know it's you, and I'll get back as soon as possible. And also you just met the author of the book. That's me, Hilary Duncombe. And you can find that book on Amazon, Barnes & Noble, or any other online bookstores. So thank you again for having me, and looking forward to seeing you guys again.
Excellent, excellent. It sure beats sitting at home. You must get up and you must exercise, everyone, diabetic or not, but especially the diabetics. And better circulation, along with some vitamin B therapy, can improve your nerve function as well, which is one of your points. And we certainly appreciate that this evening.
Thank you.
And thank you for sharing your book with us this evening. It's a fun read. And it's the type of book I like because it's not 500 pages. I got to it real quickly.
I wrote it just for you. Just kidding.
Oh, yeah, thank you. I appreciate that. Yeah, well, once again, thank you. And I'm gonna finish this off this evening with a quick presentation and a book review. Are there any questions for Hillary before we before she goes? All right. So I'm going to share my screen. Let's pull up what I have here this evening. And let's hit the share screen button first. That'll help. And let's try this. Now, is my whiteboard? I'm not getting mine up. Are you anyone to see my first page?
We can see it now. Yes, sir.
Oh, good. All right. Well, let me go right into the slideshow and play from the start. Once again, for the Zoom roundtable this evening, 27th of April, good evening. You got to get up to get down with Victor L. Horsley. And we're going to start off with part 2 of this presentation. Diabetic amputations in the Caribbean. If you don't know, now you know. And remember, you don't know what you don't know. Very important. Diabetic amputation prevention starts with preventing foot ulcers, proper control and monitoring of diabetes mellitus, recognition of the high-risk diabetic foot, evaluation and management for peripheral vascular disease, or PVD, PAD, venous insufficiency, phlebitis, cellulitis, etc., dermatopathology, skeletal and muscular deformity. Anyway, L.E.A.P, lower extremity amputation prevention of non-traumatic lower limb amputations. The 60-second general foot screen or screening, recognizing the invisible stage 1 foot ulcer that Dr. Mitchell showed us. But it looks like just a regular callus, but you get into it a little deeper and you lift the cover off and there's a big fat stage 2 ulceration sitting there staring you in the face. About 85% of amputations start with a foot ulcer. A foot is lost every, it was 30 seconds when I wrote this, now it's 20 seconds. Dr. Mitchell, thank you. Persons with diabetes have 20 times the risk of lower extremity amputations. 80% of amputations are preventable. 5 years after the first amputation, 50% of the people have the second amputation and other 50% simply die. So the prognosis, as indicated by Dr. Mitchell, is worse than breast or prostate cancer. A diabetic foot will pick up, a diabetic foot exam will pick up 30 to 50% of persons at high risk. So take a good look at your feet, at your family's feet, your elders' feet, and diabetes starts at such a young age. Look at everyone's feet, especially if they're diabetic. Let's take a good look at the annual incidence of lower extremity amputations. Here in Europe, per 100,000 people, it's 430 people. UK, it's 285. North America, 590. Okay, in Brazil, 181, not bad. In Barbados, in the Caribbean, 936 amputations per 100,000 people. So that would mean if there's 350,000 people, then we might be looking at 3,000 plus amputations per year in the Caribbean. And that's one of the reasons I'm here, which is to help everyone stop that. So we want to stop it this evening by a book review. We want to talk right quickly about The Tipping Point by Malcolm Gladwell, The Emperor of All Maladies by Siddhartha Mukherjee, Deep Nutrition by Catherine Shanahan, MD, and Luke Shanahan, and Mastering Diabetes by Cyrus Kambata and Robbie Barbaro. The Tipping Point by Malcolm Gladwell. The magic moment, the tipping point is that magic moment when an idea, trend, or social behavior crosses a threshold, tips, and spreads like wildfire. So what is the point where we can lower those 900 plus amputations per 100,000 people in the Caribbean. And when we do that, we have reached the tipping point. The Emperor of All Maladies by Siddhartha Mukherjee, just an excellent read. Now, cancer is the #1 killer in the world. And so here's a book about the history of cancer and illness, an excellent read. The Emperor of All Maladies, about the people who have soldiered through toxic bruising and draining regimes in order to survive. So this book is really excellent. Would recommend that. And it's a great read and you won't be able to put it down. Another book I enjoyed was Deep Nutrition, When Your Genes Need Traditional Food. The traditional food isn't the fast food industry, isn't the bamboo shack, isn't McDonald's and Wendy's. That's a new fad. Traditional foods are discussed in Deep Nutrition. And this Catherine Shanahan, she's a team nutritionalist and physician for like the Lakers, et cetera, and a couple other basketball teams. And she has a tendency to put people on whole food, plant-based diets, and their performance is actually outstanding on the team, and it improves because your diet improves. Deep Nutrition examines the habits that kept our ancestors disease-free, and it also examines diets around the world known to help people to live longer, healthier lives, like in the Meridian, in the Okinawa, and the Blue Zone. That's one of the Seventh-day Adventists. It's in California, where people are living to be 100. And when you live to be 100, they're not in nursing homes. They're functioning and doing well. And it's a lot of people, and a lot of it has to do with their diet and improvement of diet to a whole food, plant-based diet. And here's a book, The China Study, by Doctors, plural, Campbell. And this book, The China Study, was very interesting in that Dr. Campbell grew up on a farm in Maryland, or Virginia rather, and that they had cows and what have you. So for the first 25 years of his practice, he was a proponent for milk and meat and et cetera. He became a vegan 25 years ago, and he tells everyone at this point, don't drink any more milk, especially when milk is causing type 1 diabetes in children, and it's causing the vast majority of our autoimmune diseases. So in the China Study is how to dramatically reduce your risk of cancer, heart disease, and diabetes just by changing your diet. And finally, Mastering Diabetes in today's book club and book review. The revolutionary method to reverse insulin resistance permanently in type 1, type 1.5, that's a new one, type 2 diabetes, type 3 diabetes, and pre-diabetes and gestational diabetes. So Mastering Diabetes examines how low-fat, plant-based, whole foods diet is the most powerful way to reverse insulin resistance in all types of diabetes. And it just makes me say, what you talking about, Willis? Because everyone got choices, but it turns out you can talk to people till you're blue in the face, and 20% of the people will probably agree with what we're saying about a whole food plant-based diet, and 80% will say, nope, I'm gonna go right back to eating what I was eating. And whether you're diabetic or not, it's time for everyone to look closer into a whole food, plant-based diet and eliminate all cow and animal products, cheese, milk, ice cream, because that, in my opinion, and from reading these books, is responsible for the majority of our autoimmune diseases. Now, part 1 of my presentation was flat feet or hyperpronation, surgical correction versus prefabricated or custom orthotics. And we're just going to take a look at this little stent right quick or the next minute or so, and how this stent is changing lives 1 foot at a time. It's a game changer. And that stent goes surgically into the subtalar joint, which is the talus is an ankle bone. It's connected to the two leg bones. And the talus bone is connected to the bones in the feet, in the tarsus. And by realigning the foot to the leg, putting that stent in, then that realignment stops a lot of problems. And that's hyperpronation. When you have an arch and you lose it when you're walking, have it and lose it, have it and lose it. And you can see there's a hole in the sinus tarsi that becomes obliterated. And when this hole becomes obliterated, then that causes a lot of problems. It causes additional pressure on nerves, tendons, and arteries and ligaments of the foot. In order to put this stent in, it takes about 15, 20 minutes per foot to put the stent in. It's very simple. It is not drilled into the bone. It goes between bones to maintain proper alignment. Very simple incision on the outside of the ankle. That's a landmark right there. And as you prepare, the incision is just that long. It's about a ½ inch or less. Once it's open, you go right into the sinus tarsi. You release the talocalcaneal ligament. You put various sizes in to determine which size. And this procedure starts at age 4. All babies are born with flat feet. And as the bones develop in the foot, some develop and are developed into hyperpronation, and some develop to normal feet. And so when there's an abnormality such as hyperpronation, this stent to the rescue. And here's the stent being applied, and radiographically you can see on the floor scan once the proper size has been determined. That's the incision in the foot, very small. You put a couple stitches in, you wrap the foot up. Post-operative protocol, minimal weight bearing for the first 7 to 10 days, increased activity level after that, no running or jumping for 6 to 8 weeks, and give the stent a chance to incorporate. Once it incorporates, it's usually there for life. Even when you put it in a 4-year-old, that stent stays for life, because the younger the individual, the larger the stent. So they kind of grow into it, because as we get older, our bones shrink and our joint spaces shrink. Everything shrinks, well, almost everything. And when that shrinkage occurs in our bones and skeletal system, then we take a smaller size as we get older. So here is this repaired right foot of hyperpronation, full weight bearing, and here's the left foot unrepaired. And that's the right foot was looking just like the left foot. Okay, and here is the right foot. Now the child is learning how to walk again. Now that their foot is rebalanced, they have to retrain the brain on how your foot hits the ground. You can see the right foot still hyperpronates, and you're almost like they're walking on their inner ankle. The left foot has an arch and is in proper alignment, as it should be. And here's both corrected. So we've corrected the right and the left on the picture on the right side of your screen. On the left side of your screen is just the right one that's corrected. And here we go again with the both feet corrected on the right as compared to just one on the left. And this child is learning to walk again, and his feet are still a little sore right after surgery. And then in about 4, 6, or 8 weeks, they're back to playing baseball, basketball, soccer, running hurdles, and the brain has retrained. Their gait is anew, and they're just enjoying life after that. So once again, bilateral correction. Here's the final X-ray. You can see the red line, the talus bone that's connected to the ankle joint is angled down, and that's hyperpronation. But with either a T.E.L.E.X or a hypercure stent placed in the sinus tarsi on the bottom, it realigns the talus with the first metatarsal, which is called Meary's angle. And once you realign it to have a 0 Meary's angle, then this person is good to go. So that ends this part 3 is the end, and I thank you very much for listening. We're a little over time, but not too bad. But we do have a little time for questions. So are there any? We had a couple questions. One was from Courtney V. And if you're still on, did you have a question for Crystal?
Thank you very much, Dr. Horsley and Crystal and the others. So my question for Crystal was actually answered because the person who made a point about Washington, D.C., and that it seems as if that foot care at a certain level is being migrated over to the medical nail technician, which would be Crystal Group. I wanted to find out if that particular technician is trained to spot these, things that are not necessarily characteristic of having healthy feet, and that they would be doing the referral to the podiatrist. And I recall maybe 20 years ago, Dr. Horsley, you may have said to me that one of the first medical practitioner to probably identify that a person has diabetes is the podiatrist. So with that said, is there any formal training at the medical technician end? And I'm talking about the nail practitioner end. Is there, an effort to provide a little bit more training around caring for diabetic foot rather than some of the superficial things that are being done, or to do that referral?
That's an excellent question because
Formalized, that's what I meant to ask you. Is it institutional at that level?
I'd like to know that also. I don't know if Crystal picked this up over a couple of years or her training, if she's trained in school, but I do know that in the medical school in Jamaica, in Trinidad, they produce excellent medical doctors with an MBBS degree, and they are not trained in evaluation and management of the lower extremity nail diseases, pathologies, ulcerations, vascular problems. They know their anatomy, but they not correlating it with the biomechanics, function, and structure. So Crystal, are you still on?
Yes, I am,
Okay.
Dr. Horsley.
Oh, good. Courtney wants to know, are you trained in school to recognize various diabetic foot problems, or did you pick that up in time?
Before I picked that up in time, before I actually did my training. However, there is training once you would have gone through various courses, like I mentioned, if you would have done advanced nail technician course, if you would have done a certified master pedicurist, CMP. There is also a medical assistant to the podiatrist. So there are various courses that we would need to do to also keep up our certification and training, because there's always advancement in your field of practice. Whatever you do, there is always advancement in it. So continuing education is very important, and that is what we do within the industry. So you also have, we would have done nail pathology, we would have done evaluation, biomechanics. I am still going through my various trainings as well. So there are various steps and levels that you take within your training or your various courses. My next step, I'm going a little bit deeper into biomechanics. I've done my evaluation, infection control. We would have done the CMP, was a certified master pedicurist, and advanced nail technician, I'm sorry.
Okay. Well, Dr. Neil Horsley had a question in the chat room, and he was wondering, in the event that you would come across what appears to be an ingrown nail, but it's actually what's ischemic vascular disease. And that refers to poor blood flow to the digit. So maybe the toe, as suggested by Dr. Horsley, is just simply ischemic pain, or pain from not enough blood to the tissue, and not an ingrown nail. And I'm going to add to it, maybe it's both, but are you able to evaluate the vascular status of a digit like capillary filling time, or do you ever send them out to see a vascular specialist in addition to a podiatrist? Or what is your take on the difference
Within
between an
within
ingrown
the
nail and poor
facility,
circulation?
within the facility where I am currently at the moment, which is Foot and Ankle International, shout outs to the whole entire team. We actually
Yep.
do the 60-minute diabetic foot evaluation. So we do check for the circulation as well. However, anything advanced additional to that, we then refer over to the podiatrist, and the podiatrist then refers them to the vascular.
Excellent, excellent. Well, that's what I'm sure Dr. Horsley was getting at, the fact that you don't just do the feet and send them home. And when you
No,
see the need for additional
yes, we do the
investigation
referral.
or medical treatment, right, that you provide, you have that provided, or you make sure that's taken care of.
And
We are
additional
just,
to
Doctor,
the training that we would have received, you would see with the nail pathology, you can see the indication of that nail actually now starting to curve. So it's not even just looking at the vascular portion of it. You could literally see the nail itself is curved. And because it's curved, whether it be that of improper footwear, we know with the ladies, they love to wear the nice stiletto shoes and pointed narrow mouth toe. So definitely
red
over a period
bottoms.
of time, yeah,
Right, right,
over
right,
a period of time, because of that pressure and that the nail being then suffocating the nail bed, you have that involuted nail.
right, right, right. Um, That's a very good answer. Hillary Duncombe, the speaker right before you, is saying she's from the Bahamas and can't wait to come home because she wants for you to do her feet. So, and she loved your presentation as well. So,
Thank
I,
you.
that's
So
beautiful.
definitely if persons want to get a little bit more information on medical pedicures, or what do a medical practitioner do in the medical pedicure setting, you can find
Mhm.
information on the North American School of Podology, where I actually started my first training from. They're based in Canada. You could also check with Many Nails, which is Dr. Spalding. He's a podiatrist, and he would have done so many training as it relates to that field of practice, as well as
Excellent.
with Atina Elliott, who is a nail technician as well. You could also check with Nail Care Academy, which is another program that I'm actually in, that I'm continuing my education with.
Excellent. Yeah, well, you're in an industry that makes billions of dollars with the
An
polish, the
$8.4
treatments.
billion industry.
Yes,
We
yes.
survived the recession when we
Right.
even survived COVID-19.
Yeah, correct. Absolutely correct. And
Yes,
I
yes.
congratulate you as well.
Because
Right.
I would say during the course of everything, persons still want to get their hands and feet done. I got the many calls. I got the calls.
Right, right, right. Yeah, well, that sounds good. I have gotten most of the emails down that people have, if not all of the emails that are listed in the chat room, and I'll be including you on the invitation list, as well as if I put them in there tonight or tomorrow morning when Tiffany sends out that recording of the of tonight's video, Zoom round table. When she sends that recording, you will be certain to get all of the excellent presentations this evening. And my question is, I wondered if the chat room is also in the recording. I wonder. Tiff, do you know if the chat room is in the recording?
It is, and I
It
will
is.
also send a separate one to you as well.
Okay, right. So that's beautiful. And so if I miss, I will take a double look into the chat room when the recording comes out to make sure I've got about maybe 5, 6, 7 email addresses this evening. So I'm going to take another look in and make sure I didn't miss anyone, so we can be sure and share this valuable information.
It will be
Tiffany,
sent in a separate file.
pardon me?
It will be sent separately from the
Oh.
recording.
I see. Okay. Well, beautiful. I get a chance to take a look and see what's going on. Well, any good news coming from H2K Canada, Tiffany, with the Boratotal or the Diabasoft? Everyone's still enjoying those products?
Definitely, definitely. We should have our case studies out shortly, so that way we'll be able to see firsthand results from, patients and persons that have tried the product and seen how effective it is. So we should
Right.
definitely have that coming as soon as possible. I would say maybe by the end of May. We should hopefully have that in hand.
Excellent.
We were
Well,
told
good.
by the summer, so I'm hoping for May, so that way we would be able to include some of them in our presentations, and people can see firsthand, like I said, how effective it is.
Okay, that's beautiful. And then we'll check with the company and get some before and after photos too, and have you come on next month, as you
sure.
are every month, and share some of that good information with us. Well, we want to thank you, Alexandria, and thank you, Tiffany. Thank our audience this evening for chiming in with us, taking time out for those who can make it, and taking time out to accept our copy of the video. Please contact us at Caribbean.dfu, which is diabetic foot ulcerations, .mis, minimally invasive surgery, @gmail.com. And you can request it, but I do have the request from the evening's emails. And are there any last questions or anything anybody wants to say before we close this evening?
There are 4 hands that are up.
All right.
Hi, Dr. Horsley.
Hi.
Hi, Dr. Horsley. This is Steffi. I have a question. My son is an amputee for the past, I guess, about 7 years now. And he
Right.
have what you call he calls phantom pain. What causes that?
Right.
What causes
Phantom,
phantom pain?
it's just a training of the brain to recognize that at one time, both limbs were present. And when you mention amputation, it's very important for your son to be seen by a podiatrist at a minimum of once a year to evaluate the contralateral limb or the other leg, and make certain that that other leg does not have a problem, which will lead to a double amputation within a 5-year period. Any other questions?
I have a comment. I wanted to also say, in terms of training for the nail technicians, as a
Yes.
podiatrist, we're involved with training in terms of partnership with the nail technicians to make sure they're, especially with the diabetic foot. So locally, we have been involved with a number of the organizations, the nail technician organizations, to help them with training, as well as BTVI, that will assist them to kind of keep up to date about, especially with the diabetic foot, and to make sure that they're able to perform their job in the best way and identify problems with the diabetic foot. So that's also an avenue or opportunity for training that is usually offered by the podiatrist. So I just wanted to mention that as well.
That's a good point, because as you know, Dr. Mitchell, they have first contact. People will be more likely to go get a pedicure and a manicure before they go see a doctor. And that's everyone. And so when they do, and the foot is high risk, and it's nice that a well-trained nail tech knows that 60-second foot exam, and when performed, can identify certain problems, whether it's a deformity, poor circulation, possibly a nerve or polyneuropathy, a nerve deformity. And when the nail tech can identify these pathologies or these problems, then that saves people from having amputations, that alone. And without even going to a doctor, you can just go, you have been to a nail tech who actually began the process of saving your toe, foot, or leg. So we want to thank you, Crystal. We want to thank you, Hillary, for telling us about, actually reminding us that the pandemic is coming to a slow close, to an end. The masks are trying to come down around the world. People are getting back out. We're not locked in the house anymore for 17 months. The clubs are back open. For Hillary, yeah, we can go dancing. The beach was closed here in the Bahamas. I can go swimming again. So it's time to get out the chair, get out the house, not this time of night, of course, but first thing tomorrow, get up and exercise. And remember, do your stretching, touch your toes, do some trunk twists, reach to the sky, or download a yoga app. Also, one of our viewers, Marlene McKinney, she does a 5 o'clock a.m. exercise program online. So you can contact me through the methods as we've already discussed, how to join up with Marlene McKinney. It's something better, and she has a vegan eatery. So it's what is it, a pop-up? I think it's called here. So a pop-up kitchen. So you can get your soups, your king burgers, your veggie lasagnas, your quinoa, brown rice. You can get all the foods that sustain life, as opposed to eating just plain white rice, white bread, and food of no value and is no substance whatsoever. And you want to avoid those foods as much as possible. So once again, thank you, everyone. One more question? Yes.
Yes, Chuck Perry here. I wanted to ask you about the EOTTS procedure. How often do you have to take those stents out?
Hey, Chuck, that procedure has a 94% success rate. And of the 6% that need to be adjusted, some actually do come out, yet others might be downsized. So of that 6%, maybe 3%, you go from a size 7 to a size 6, or sometimes you go up a size. You may have put in a size 8, but when post-operatively, you take a look at the gait and there's still some hyperpronation present. So sometimes you have to go up a size, but it has a 94% success rate. And I've done over 500 of those procedures, and I found that it to be just a game changer as far as realigning the foot to the leg and the foot to the supporting surface.
I have a question.
So for children
I'm
that
sorry.
are asymptomatic, you still put those in?
Yes. When they're asymptomatic, I also put them in because, for example, a cleft palate is asymptomatic. You know, you have a big slit in your lip and food falls out every time you eat. It doesn't hurt, but you want to look normal. Is that a mushroom burger or a veggie burger you're eating there, Chuck? For the don't answer.
I didn't know my camera was on. Sorry.
I'm glad it was just a burger you were doing. But yeah, it's no problem with the adjustments of the EOTs whatsoever. We'll be in good shape. Any other questions, Chuck? Are you
That's
good?
it. Thank you.
All right, buddy. Thank you, sir. How
Doc-
about you, Hillary?
Yeah, I was just wondering, I noticed that you said it started from 4 years old. So what happens if you perform that same procedure on an adult? Like, what are the risks?
The biggest risk I find on an adult is that you've waited too late. So if you catch the younger, the better. You catch the deformity, even though it's asymptomatic or without pain or problems. The earlier you catch it, the better. So I've done an EOTS procedure on a 12-year-old, and that very day a 24-year-old was in, and the 24-year-old could not be repaired. It was a stage 4 hyperpronation, which was unrepairable. The bones had begun to crush in the foot. The midfoot had begun to collapse, and it has collapsed beyond the point of repair. So what we do is we have to go to other extensive surgeries, sometimes at age 24, to do, let's say, arthrodesing or fusion of the bones, what they call it calcaneal slide, where I cut the heel in half, like doing a cucuteanis, or some type of Dwyer procedure and put 2 major screws through the back of the heel to realign the foot, because you could see where that ankle, that medial ankle was protruding, like they were walking on their inside ankle bone. The earlier you catch that, the more flexible the feet are. It's easier to snap that foot back into the right correction mode, put that stent in, and the stent holds it in the corrected position forever for 94% of the people.
Now that space that's in the middle that you have to put the screw through, because you said it doesn't go through the bone, it goes through that space area. Does that,
Yes.
does that space change or just diminish with age?
Yes, it does. So if I ever get my hyperpronation fixed, I'll probably take one of the smaller sizes, because I have fractured my talus a time or two. And there's a lot of arthritis in my subtalar joint. So had the procedure been around when I was 12, there was a similar procedure called the MBA, the stay peg. It was an attempt at putting something in that hole. But Dr. Michael Graham, he modified the type 1 stent into a type 2, where that hole has one component called the sinus tarsi and another component called the sinus canalis. Well, Dr. Graham modified it where the stent actually goes into both sinuses and it balances the talus and corrects it instead of just propping it up and filling up the hole.
Mm. So the downtime, is it still going to be 8 weeks with an older patient?
Well, the downtime is really no downtime. You're always up, whether it's with a walker, a cane, you're moving right away. And in 4 weeks, you're back to regular activity. Of course, the younger you do children, and in about 2 weeks, they're back in their gym shoes and walking around out of the special boots. So the younger, the better, but you can do it on somebody that's 92 years old if they meet the criteria.
Okay, thank you.
You're welcome. Well, once again, thank everybody for chiming in with us this evening. We went over time a little bit, but it was fun. And thank all of our guests, Dr. Mitchell, Hillary Duncombe, Crystal Woodside, and I thank myself because I was so happy to give a little lecture tonight. And I look forward to seeing everybody in 4 weeks. So this is April. So sometime in May, whatever the last Wednesday in May is, mark that on your calendar and get on our mailing list so we can send you invitations with no problem. All right, thanks everybody.
Dr. Horsley, before you log off, Dr. Jefferson has had his hand up for a minute.
Say what again, Tiff?
Before you log off, Dr. Jefferson has had his hand up for a minute.
Dr. Jefferson?
Yeah, Doc. I just wanted to again put out a shameless plug for the NMA convention at the end of July.
Oh, right. The National Medical Association is meeting in Atlanta. And National Medical Association, about how many physicians and healthcare workers are planning to attend that meeting, Dr. Jefferson?
Well, there's going to be thousands. How many are going to be there in Atlanta? I'm not sure, but it's also going to be hybrid. So if people want to join virtually, that's an option as well.
All right. And the dates are July the 30th?
July 30th through August 3rd.
August the 3rd. Excellent. Thank you for that reminder.
And the podiatry section will be robust.
Okay. All right. Excellent. Excellent. So we'll look forward to this because they have a lot of breakout sections in the NMA, podiatry, orthopedics, neuro, derm, you name it. They have various breakout groups. And the podiatrists joined the MNA, was it maybe 6-7 years ago?
6 years ago.
6 years ago. Yeah, we used to be the NPMA. Now we're with the NMA, and it is just a fantastic move for everyone involved. So thanks for that reminder. Really appreciate you. And if you're in Atlanta, I'll see you at that time.
I'll be there, bud.
All right, my brother. Appreciate you.
All right.
And everybody,
Thanks again.
everybody else appreciates you as well. Tiffany and Alexandria, any last words?
We just want to thank everyone and thank you for allowing us to host, the Zoom presentations. And remember, everyone, prevention is better than cure. So if you have your family members, friends, persons like all of the other speakers and persons were trying to indicate, just check your feet regularly. Make sure that you catch it ahead of time so that you can avoid having to, have any amputations or have any major complications.
Right.
Diabasoft, Total, local pharmacies.
All right. Nicely done. And Tiffany, thank you for being one of our hosts also and getting the recording together. And we really appreciate the work you and Alexandra are putting in to make this successful and to lower the amputation rate by 50% in our diabetics in 5 years.
It was an absolute pleasure. It is at the end of every month. It is a wonderful learning experience. And you guys have me terrified. I'll just put that out there.
I know, Dr. Mitchell. Hey, we're putting her last. Her lecture was excellent. She goes last next time, making us look bad like that. All right. Well, thanks again, everybody. And we want to say good night. And maybe you'll get to your late night dinner snack or tapas, or maybe you're going to have a cocktail, or maybe you're just going to lay down and relax. Whatever you're going to do, appreciate you spending this time with us and hope to see you next month. So bye-bye, everybody.